So it's very important to understand what the components involved in adequate ventilation or oxygenation are. So it's obviously starting from the neural control of respiration. So we have the respiratory centers in the brain, and this plays a very important role when we discuss a condition like apnea of prematurity. But the background maintenance of the respiratory rhythm and the support to the breathing, the increased work of breathing that is needed with the respiratory condition is part of the central drive as well. The neural control works on the muscles of respiration, which subsequently control the way the chest wall works. And as we will discuss, the chest wall complaints and the various factors relate to the tone of the muscles as well. The airways are very important, and in a premature baby, the patency may be compromised. There may be conditions like congenital anomalies like a vascular ring, which can affect the patency. And of course, the compliance is affected by the stage of sleep or the tone of the baby. For example, obstructive apnea can be contributed by the collapsibility of the upper airway. And keeping it patent is one of the advantages of non-invasive ventilation as well. We then move on to the lungs, where we have components like alveolar maturation, surfactant production that play a role, and this depends largely on the gestational age of the baby. We will discuss this in more detail when we are discussing the pathophysiology of neonatal respiratory distress syndrome. The chest wall compliance is very important as well. And when the chest wall is soft and is a premature baby, it's of a very high compliance. And so it's very important that we support the chest wall from collapsing, which takes the lung with it. So suppose you have a high compliance chest wall with a diseased lung, which is usually low compliance in a newborn with RDS, for example. When the lung tends to close, the chest wall is not able to resist that force and keep it open. The chest wall goes in, and that's what we see as retractions. The pulmonary circulation is in a transitional stage after birth. There is often physiological shunting, and we call it physiologic persistent pulmonary hypertension. And PPHN is an accompaniment of many lung diseases. The severity of it may vary, and it's very important to diagnose it early so we don't flog the lungs in the presence of shunting, which is actually the reason for hypoxia and not the lung disease. So this overview of the factors involved is key, because we can break down the cause of the respiratory problem, the cause of the difficulty in oxygenation ventilation into any of these components, and the principle or the approach of your management the approach to the management will depend on these underlying factors.